When we talk about cardiac output, we're referring to the amount of blood that is contracted, pushed forward out of the heart with each contraction, each cardiac cycle, each heartbeat. A simple way of remembering cardiac output is that it's a combination of heart rate and stroke volume. And we'll go through each of these, but it's just a simple matter of the faster the heart beats, the more blood it's able to pump. And the more blood it's contained in each contraction, the more forward blood flow you're going to have and the more perfusion. So we'll break each of these down a little bit. Heart rate is the body's quickest, most immediate way to respond to a difference in demand, a difference in perfusion, a need for more pressure, a need for more oxygen, that sort of thing. That's done through its central nervous system. The sympathetic side of the nervous system is responsible for increasing the heart rate. The body sends out norepinephrine and epinephrine, which causes an increase in the rate as well as the force of the contractions, and that speeds up the heart rate. If, on the other hand, the body senses the need to slow things down, the parasympathetic side of the nervous system does that through innervation of the vagus nerve, a slowing of the heart rate, which decreases cardiac output. Stroke volume is a little more complicated, but we can break it down into three key components. The first is preload, and simply put, that means how much blood is coming into the ventricles prior to those ventricles having an opportunity to squeeze. That's the blood flow from the vena cava, the deoxygenated blood coming back from the body into the right side, and also the oxygenated blood that's coming back from the lungs into the left ventricle. The amount of blood flow coming into the heart is obviously going to impact the amount of blood available to be pumped forward. The next part of the equation is afterload. And when we talk about afterload, we're really talking about blood pressure. We're talking about the amount of pressure that the heart has to overcome in order to push that blood forward into the circulation. And that applies to both peripheral blood pressure, systemic blood pressure that we typically measure when we're measuring a patient's vital signs, but it also applies to the pressure that's present inside the lungs. So when we talk about pulmonary pressures, pulmonary hypertension, we don't have a way in the field to measure pulmonary pressures. But if there is a disease process or something going on that's increasing the pressure in that part of the vasculature, then obviously that means the right ventricle has to work harder to move blood through that area. The third thing that we talk about is contractility. And contractility is simply the squeeze. How hard, how much force can the heart squeeze with in order to move that blood forward? And there's several things that actually impact that strength of contractility. As I mentioned before, the body through the sympathetic nervous system can stimulate the heart to increase the force of those contractions. If you increase preload, more fluid going in tends to stretch that muscle, and it basically rebounds back. It's referred to as the Frank-Starling mechanism. And it gets increased squeeze, increased contraction because of the increased fluid that's stretching it out. And finally, in the variety of disease processes, cardiac disease, especially in the presence of myocardial infarction, you actually lose some amount of muscle tissue in the heart, which decreases the ability of the heart to contract, sometimes permanently, and significantly changing the amount of cardiac output that a patient can produce. The entire system is really a matter of supply and demand. When we talk about cardiac output, we're trying to evaluate, and when we talk about patients in distress, we're trying to evaluate, does their cardiac output produce enough output to meet the demand within their system? Well, how does the body figure that out? How does the body determine what that demand actually is in order to match the supply? The way we do that is through various receptors in the body. And there's a number of them in other places. There's a number of fine details. But the most important ones to remember is that we have baroreceptors. Baroreceptors are pressure sensors. These are located primarily in the carotid sinus, as well as in the aortic arch and in the coronary arteries. And those baroreceptors are sensing the amount of pressure, how much pressure is stretching against those vessels. And it sends those signals to the brain to indicate that more pressure is needed or less pressure is needed, which then triggers those sympathetic or parasympathetic responses that I mentioned before. The other thing that we have is chemoreceptors. There are chemoreceptors located in those same spots, as well as in the brain. And just like the name would imply, they're measuring chemicals. In this case, we're talking about carbon dioxide, oxygen levels, and pH, how acidic or alkalotic the blood is. The brain is constantly getting these signals from chemoreceptors to indicate that we need more oxygen. Sometimes those signals are going to the lungs to increase oxygen, increase airflow, increase breathing. But in order to get that oxygen to the brain, it also needs to increase blood flow in most cases. And so the chemoreceptors and the baroreceptors are sending those messages from the brain to the sympathetic and parasympathetic system to stimulate the heart to create the amount of output that is needed. That same response is going to happen whether your increased need is from exercise, for example. If you're exercising and exerting yourself, you're going to need more fuel. You're going to need more oxygen, more glucose, more electrolytes, and the body senses that demand, and through the system I just described, increases the cardiac output to meet that need. Similarly, in a disease process, something as simple as dehydration, if you don't have enough fluid in the tank, if you don't have enough fluid circulating, your pressure drops. And that drop of pressure is sensed through those mechanisms to make the body realize, to make the brain realize that the body needs increased perfusion. And again, those stimulations happen. That's why in shock states, it's so important to recognize these clues of increased compensation, increased effort on the body's part to try to maintain cardiac output. That's why we see tachycardia. That's why we see pale skin. It's all part of that sympathetic response as the body adjusts to try to make that cardiac output match the needs. In summary, cardiac output is a result of your heart rate and your stroke volume. Increase either one and cardiac output goes up, decrease either one and cardiac output goes down. If one decreases, stroke volume, for example, as I just described, then the heart rate is going to go up to try and compensate for it. Stroke volume is determined by three factors: preload, how much blood is coming into the heart prior to each contraction; afterload, how much pressure does the heart have to overcome to move blood forward; and contractility, what ability does the muscle have, that heart muscle, to actually squeeze effectively and move blood forward. The baroreceptors and chemoreceptors in our system determine what that demand is. They sense the clues. They pick up on these cues that tell the brain, we need to adjust things. We need to change. That's how our body meets demand, or creates the supply to meet the appropriate demand. And those sympathetic and parasympathetic nervous systems adjust the supply to provide what's needed. The system is constantly in flux. These changes happen within seconds and can be sustained for an extended period of time. But in disease states, there are often many circumstances where we can see the evidence in our patients that those compensatory mechanisms are wearing out. And that's where we see evidence that the cardiac output is now declining despite the body's efforts to try to maintain an appropriate perfusion.